Hi, John.
That.
It's Anita. Hello.
Oh, hi, Anita.
Hi, how are you?
I'm good. Good. Busy, busy, busy.
I can only imagine.
There's a
Like,
lot. These guidelines have stimulated a lot of interviews and requests for talks and all good things because the last thing you would want would be if you're a group of people, like the task force was to spend all this time and effort and then not have anybody pay attention. Um, but it's just been very time consuming.
I can only imagine. I know you said you have to go right from here to a different Grand Rounds. I think you
University
guys,
of Calgary.
yes. So,
Luckily, I don't have to fly from Ann Arbor to wherever. Yeah.
yeah, Alberta. Yeah, thank you for doing this. I really very much appreciate it. So it'll be great. I'm sure people have lots of questions for you, as I'm sure you've encountered already in
Yeah.
all of the talks you've given.
I was just did UCSD yesterday,
Oh, yeah.
and because one of our first fellows at I don't know if you know Atul Malhotra,
Oh, yeah.
uh, kind of runs the research program there, and there's a number of good questions from the providers, the audience there. Yeah.
Yeah. Yeah. Oh, great. Do you get a little break for the holiday?
Oh yeah.
Oh, good.
Starting the 13th. I'm just gonna, we're going away
Nice.
for almost a month, not seeing
Oh,
any patients,
where are you going?
going to two different places. We have friends of friends who have a house in Vieques. Do you know where that is?
I do not.
It's a little island off the east coast of Puerto Rico
Oh,
that's
wow.
pretty rural, quite rural.
Nice.
And they come up to be with their grandkids um, up to Rhode Island, and they were both former MGH doctors, and said, "Do you want to stay at our house when we're up here?"
And
And at first, I said, "Oh, I couldn't," and they said, "Yeah, really?" And I said, "Okay, I could."
okay, sure.
So that's where we'll mostly be,
That's incredible. It'll be
and
great.
then and two of our kids will be able to join us.
Oh, nice.
Third is a PGY2 who is working Christmas Day, day
Oh,
after Christmas, Christmas Eve.
yeah.
Yeah.
Oh, goodness.
Yeah.
Remind me what specialty again? Is it psychiatry?
Yeah. She's
Yeah.
going into psychiatry.
Yeah. That's awesome.
Yeah.
Following
She's
footsteps.
excited. Yeah. I mean, even though I took a radical turn
Mm,
immediately away from psychiatry,
yeah.
but my wife's a child psychiatrist.
Nice. Turn on my light. Well, that'll be great. Have an awesome time. It's like
Thank you. Are you going to
hard
get to go?
earned. We are hosting Thanksgiving and then we're going to Florida for a week in December to my parents' winter down there. So
Oh,
it'll be good. We'll get some sunshine then.
yeah. And some
Yeah.
warmth because
Yes, exactly.
it's cold. Yeah. My nephew is at PGY3 and PGY 3 in radiology, uh, where you are.
Oh, really?
Yeah, working pretty
Oh,
hard.
yeah, I can imagine. Oh, small world.
I should have told him that I was giving
Yeah.
Graham, although I'm sure he's locked in some room reading,
Well, if he ever
PT.
needs anything, please feel free to give my info. He's been here a while. So
Okay, that's very nice. Thank you. And if
yeah.
you ever need anybody to read a scan, scan, use my same last name.
Oh, okay. Cool. Right. People are starting to file in here.
Yeah.
Just give it another moment and then get
No
started.
rush. I mean,
Okay.
I've got more slides than I can get to.
Okay.
So maybe I should start screen sharing now. What do you think, Anita?
Yeah, sure. Go ahead and try it and then we'll see. I'll let you know if there's any issue. It's in like the work mode, not the presentation mode.
No, it's not good. But I
Like we
switched
can
it.
see all the
There we
slides
go.
on the, yeah, perfect.
No, no longer.
Yep, all good now. Great.
Let's wait till everybody arrives. It's nice if just at least one person actually has their live human face there so that when I tell a joke, I can see if somebody laughs. Because otherwise, um, this is for people who like to speak publicly but enjoy the back and forth. This Zoom thing is really is death. It takes all of the juice out of it.
And we'll make sure to turn off cameras if we choose not to laugh. No.
Yeah, if you want to stick your tongue. No, I just like some connection.
Yes, totally hear you.
But I'm very happy that I don't have to, not that I don't like Ann Arbor, but that I can do these, a bunch of these this way.
Absolutely. And I can keep an eye on the chat and like kind of save those questions for the end
Yeah.
as you're going through your presentation.
Yeah, thank you. Thank you. And I'm going to try to finish early, which means I'm going to talk fast. And I
Perfect.
guess if there are brief questions, we can discuss them in real time.
Okay.
They're really elaborate questions, then maybe not.
Okay. Well, we will go ahead and get started. So it is a pleasure to welcome Dr. John Winkelman to our sleep medicine ground rounds today. Dr. Winkelman received his PhD in psychobiology from Harvard University, his MD from Harvard Medical School, and then completed both residency in psychiatry and sleep medicine fellowship at Massachusetts General Hospital. He was a medical director of the sleep program at McLean Hospital and subsequently medical director of the sleep lab at Brigham and Women's Hospital. He's currently a professor of psychiatry at Harvard Medical School and chief of the sleep disorders clinical research program in the Department of Psychiatry at Massachusetts General Hospital. His research has primarily focused on epidemiology, physiology, cardiovascular consequences, and treatment of restless leg syndrome, and neurobiology and treatment of insomnia. He has lectured in postgraduate and graduate medical education courses nationally, internationally, very well known for his expertise in many things, particularly in restless leg syndrome. He did an incredible job spearheading this task force to publish these updated guidelines on the management of restless leg syndrome. So thank you so much for sharing your time with us. I'll turn it over to you and welcome again.
Thanks, Anita. Thanks for inviting me. Good to see a number of familiar faces out there who are actually live faces with full facial expressions. Thank you for joining. A lot to talk about, so I'm going to move forward. A number of conflicts of interest for you to consider when listening to the content of this presentation. Number one, I got funding from a not-for-profit neuroscience foundation to build a website that was kind of like a Reddit forum, but it's for peer-to-peer communication. It is free, it is non-commercial, HIPAA compliant, and you do have to show your healthcare license to be registered. But then once you get beyond that, there is a kind of a template where you can put in patient information about difficult restless leg syndrome patients. And we have, I don't know, roughly 125 people who participate in this and are communicating about patient issues. So I would take advantage of this if you do see patients with RLS. Quick case presentation. 39-year-old. She says she has problems sleeping, has uncomfortable feelings in her lower legs, that are associated with an urge to move. It's relieved when she stands up or walks. She had similar feelings while she was pregnant. Symptoms begin in the evening, worsen when lying down, extending time to fall asleep by 1 or 2 hours, about half of the nights. There's a few little points in here that should just ring little bells. She had gastric bypass surgery, panic disorder. She's on fluoxetine. Labs, hemoglobin of 12.6, ferritin of 25, and a TSAT of 14%. She goes to see her neurologist, who says, "Oh, your iron's low. I know that iron is important. Let's give you 1,000 milligrams of iron." Didn't work after 3 months. So they initiated ropinirole, 2 milligrams at 8 o'clock. Immediately got rid of symptoms. The patient was extremely happy. The doctor, she was very happy. She got some chocolates and flowers from her patient because of the gratitude. 16 months later, the patient came back reporting that evening and bedtime symptoms were okay, but now she was having symptoms that were waking her up in the middle of the night. And it was taking her an hour or two to fall back asleep. Iron testing now is completely normal. And so what's a doctor to do? At the beginning here, we see the honeymoon with dopaminergics, the honeymoon. Then we have what we're going to see when the relationship goes sour. So the neurologist, she said, okay, why don't you continue taking your ropinirole 2 milligrams at 8, 7 o'clock, maybe that'll handle your evening symptoms. Let's give you another 1 or 2 milligrams an hour before bed, and that'll handle your symptoms in the middle of the night. Again, chocolates and flowers, she's a hero. Patient comes back 8 months later and says, evening and nighttime are okay, not always great, but now, I find that when I'm at work, I have to stand up at my desk. And sometimes when I'm driving home, my legs are just so restless and uncomfortable, I need to get out and walk around a little bit. Iron studies still normal. For anybody who's over the age of something or other, they may have heard of Will Rogers, a famous American, I don't know what he was, pundit, who says, if you find yourself in a hole, the first thing to do is stop digging. And unfortunately, many of us in sleep medicine don't listen to that. And we keep digging and digging and digging until we are over our head. And at that point, we say in the community, the neurologist says, I don't think you're supposed to use more than 4 milligrams for RLS. We can do 6 for a while, but then I'm going to refer you to Dr. Shelgagar or Dr. Chervin, and they're going to bail me out of this hole that I've dug myself. Okay, I don't need to tell you what restless legs is. I think that this acronym is useful for patients because you can explain to them how you make a diagnosis, URGE, then it helps people. This is an easy way for them to remember how you made the diagnosis. Where does RLS stand in the universe of sleep disorders? Well, of course, chronic insomnia is by far the most common sleep disorder. Second would be sleep apnea, third RLS, and RLS is about 50 times as common as narcolepsy. You see that there are a couple of important things that influence the prevalence of RLS. The main two things are age and relatively linear increase from the age of 20 up till about 80. And women have about double the prevalence that men do. We, in the past, divided RLS into primary and secondary forms. In fact, the phenotypes are really identical. There may be small modifications, but they're basically the same. And so RLS is RLS, and it seems to respond in general to many of the same treatments. The important thing to know are these reversible causes, what used to be called secondary RLS. Iron deficiency, end-stage renal disease, oftentimes with dialysis, pregnancy, peripheral neuropathy, there's RLS is common there, serotonergic antidepressants, and an area that I've gotten involved in over the last few years is opioid withdrawal, where a third to a half of people who are withdrawing from opioids who never had RLS before now have RLS during, certainly during the acute and oftentimes the subacute period of withdrawal. And unfortunately, many of them long-term, even though they may be on replacement therapy. When we talk about RLS treatments, it's important for us to recognize that when you initiate a treatment, you're going to be talking about long-term for most people, because most people with moderate to severe RLS continue to have symptoms. They certainly wax and wane, because RLS is a fickle disorder. I like to say that people will have it bad for a week or two, and then it goes away for a week sometimes in the moderate, not generally the severe cases, but it waxes and wanes. But it is usually unremitting if you have moderate to severe disease. So we're talking about treatments that we need to think about the long term. In a 50-year-old, we're talking about 30 plus years of treatment. So unless you expect the honeymoon to last for 30 years, which some of us are lucky enough to have, we need to be thinking about treatments that have that kind of durability. Briefly on pathophysiology, there's now a nice paper that just came out in Nature Genetics, reinforcing these same genes. We have a number of really good genes for restless legs. I mean, it's impressive. Of the sleep disorders, this stands out as having a really strong genetic influence. And if you do a polygenic risk score, you can get about 20% of the variance for the presence of RLS with the genes that we have. And first described in 2007 in simultaneous papers in Nature Genetics and the New England Journal, and really now just expanding the number of genes over these last 20 years. The other thing in pathophysiology has to do with iron. RLS is a brain iron deficiency for many people. Here's one of the first papers that documented this and shows it very well. CSF ferritin on the y-axis, serum ferritin on the x-axis. For any given level of serum ferritin, look at the difference between people with RLS in blue and those without RLS in red. There's something wrong with getting iron into the brain or managing it within the brain, in something wrong in RLS. And iron is not passively diffused across the blood-brain barrier, but it's actively transported by metal transporters. And there's a lot of science there. We don't quite understand what's going on in RLS, but iron plays an important role. We do need to remember that most people with RLS, when we do serum iron indices, they're going to be normal, within normal limits. But we have a higher threshold, I like to say, in sleep medicine for people with RLS. We answer to a higher threshold than just regular iron indices. One of the lovely features of restless leg syndrome are these periodic limb movements of sleep. When I started doing sleep 30 years ago, these things were just so cool, just so beautiful. I don't know why, I'm some kind of fetishist, I guess, but I find these really lovely things. And they're even maybe more beautiful when you can see them in a digital display, because rather than paper, you can scrunch it down and see 5 minutes all in one screen, and you can just see the lovely periodicity of them. And for many years, I was quite involved in these leg movements and in the heart rate and blood pressure modifications that were associated with these periodic leg movements. And as you can see, many of them are associated with EEG arousals. I'm not going to talk in any great detail about these leg movements other than to say, if you like leg movements like me, we're all, I guess, in the same kind of fraternity. So here's restless legs, the stone in the pond. And what are all the ripples? Well, we just talked about PLMS. We certainly have sleep disturbance in RLS because, for obvious reasons, it's a disorder that is associated with the need to move and uncomfortable feelings in the legs that are relieved by movement at night. That's a recipe for a sleep disorder. There is an association, both cross-sectional and longitudinal, with cardiovascular disease, certainly a cross-sectional association with mood and anxiety disorders, as well as reduced health-related quality of life. So let's move on to treatment now that we've got the background behind us. And I'm starting with these new guidelines right up front, rather than burying them later after I describe all the different treatments, because I will go on to describe the different treatments that are in these guidelines. But first, I'm going to talk about the recommendations from the task force. And here you can see members of the task force, as well as other members who assisted the task force. See one of them here, who were really instrumental in all of us putting this together over a 5-year period, meeting monthly to assess the thousands. I think there were 1,500 studies, clinical studies that we looked at and did, with the help of the ASM staff, very elaborate meta-analyses. These are guidelines, also known as recommendations. They are not requirements. They are not prohibitions. Anybody here who has a license to prescribe medications, none of us on the task force are taking that away from you. But these are recommendations for what we think is best practice at this point in time about what is known about RLS treatments. We start out with good practice statements, things for which there is not clear evidence base, but we think that these are valuable places to start. First, rather than treating the RLS, you want to look for things that might have caused it that's making it worse and see if you can mitigate those. Alcohol almost always makes RLS worse. Antihistamine, same thing. Serotonergic drugs, things that block dopamine receptors, untreated sleep apnea. See if you can address those and how much of the RLS goes away. Number 2, every patient who's in your office with restless leg syndrome should, the first time you see them, they should not leave without you filling out a requisition for serum iron indices, and not just ferritin. Ferritin is a sensitive marker of iron deficiency, but it is very clearly nonspecific because, as we all know, it's an acute phase reactant, and just about anything that's inflammatory will make ferritin go up. So you can easily be fooled by ferritin, but also get an iron and TIBC. And iron divided by TIBC, of course, is transferrin saturation. And always tell your patients, for the 2 days before you get your blood testing for iron, no iron-containing vitamins, no red meat for 2 days. And I say to people as a way to help them remember, I say, look, Mrs. Smith, I want your iron level. I do not want a hamburger level. Because red meat in the morning or the night before drive up the iron, transferrin saturation will be falsely elevated. And number 3, RLS is common in pregnancy. And if you're going to prescribe, then use the usual precautions. So the grade system that ASM uses has 4 levels of recommendations. Recommended for and recommended against, and strong for, conditional for, strong against, and conditional against. So there are really only 4 buckets you can put these approaches in, or else if you have inadequate information, you can just say that. Do you hear that scraping noise in the background, or is it just annoying me? Okay,
I don't hear it.
It's just annoying me. At one point, I may want to go upstairs and ask the person to stop scraping. Not a noise you usually hear in your own house, but we're having some work done here. So, what are the strongly recommended treatments for restless leg syndrome? Easy to remember. They're the alpha-2 delta calcium channel ligands, gabapentin, gabapentin carbonyl, and pregabalin. And one member of the IV iron family. As you'll see, there are others that are going to come. So those 4, and much of this is new since the 2012 recommendations. That was the last time the ASM made recommendations about RLS, 12 years. It's a long time in sleep medicine, which, as you know, is moving at a breakneck speed. And there's a lot of new data on these treatments. None of them were the highest recommendation then, and now are because of new data. This is where I would encourage you as your first lines of treatment. Next are conditionally recommended. We might say second line if we were going to use that kind of terminology. Another form of IV iron, intravenous low molecular weight iron dextran, oral iron ferrous sulfate. There's one randomized controlled trial for dipyridamole, the drug formerly known as Persantin. You know, many of us used that when we were interns and practicing medicine at that point in time. All of the mu opioids. So the best data is for oxycodone extended release, but the task force felt that this was a class effect and that all mu opioids could be considered conditionally recommended for adults with RLS. And then the new treatment, the bilateral high frequency perineal nerve stimulation, that's kind of just getting rolled out now across the US. And which has one randomized controlled trial and some other open trials. Now the big change. Is everybody ready? Against all of the dopaminergic medications, we are now conditionally recommending against their use as first-line treatment for RLS. Not because they don't work. They work extraordinarily well. But the grade criteria, the grade system balances benefits and side effects, just as we would as healthcare providers. We balance these things for each patient, both short-term and long-term. And the task force felt that the weight of the evidence was against the presence of augmentation, which we'll talk about in a minute, led to greater side effects over the long term than the benefits of short-term efficacy. And this has been a great disappointment for me. I'm not going to get too personal here. I think Anita has heard me give this shtick before, but this has been a great disappointment to me that these dopaminergics have ended up this way. I was the first author on the published pivotal trial in 2006. It was published in Neurology. That was a pivotal trial for the approval of pramipexole, a great drug for RLS. And I thought we had solved RLS 20 years ago. It became quickly apparent, though, that that was not true and that people were getting worse. And they didn't get worse immediately, as we'll see with these other medicines. Alpha-2 delta calcium channel drugs. You get a side effect of sedation or instability or dizziness. They're coming back and telling you that within weeks. It's obvious, it's immediate. With these medicines, it's years of a slowly insidious worsening. And unless you're paying attention and asking regularly, you may not notice. This is the real issue, is that it happens so slowly. So we now conditionally recommend against their use. However, for patients who place a higher value on the reduction of RLS in the short term and a lower value on adverse effects, here we mean augmentation over the long term, they could reasonably select these medications for RLS treatment if you agreed with that approach. You're the one prescribing it. The patient's the one making the decision. I say to patients, look, I'm just like Waze, you know, the app Waze that tells you how to get places. I'm just like Waze. I'm saying you can go this way, you can go that way, you can avoid tolls. The long way is going to take a little longer. I'm making suggestions. In the end, you decide. But there may be times when I say, I understand that's what you'd like to do, but I'm not going to, you're going to have to find another provider. But if you agree, patients may choose this. Now let's talk about these drugs in some detail, and then talk about augmentation, and then talk about how to overcome augmentation. So we're going to blow through these pretty quickly. The alpha-2 delta agents, iron, opioids, and the dopaminergics. Gabapentin, gabapentin anacarbol, pregabalin. They are really good medications for restless legs. They have side effects, which will be apparent pretty quickly. And they will tell you sedation, dizziness, weight gain, gait instability, cognitive dysfunction. No evidence of augmentation with these medications. The weird thing that the pharmaceutical companies never told us about gabapentin, which is really important that we recognize, it has non-linear pharmacokinetics. Look what happens as you increase the dose to concentration. This is gabapentin anacarbol, which overcomes that problem. Look what happens to gabapentin. Giving 1,400 milligrams is not 7 times what 200 milligrams is. It would be up here. So the receptors in the gut can only take so much in at a time. So for people who are on gabapentin who can adhere to this kind of dosing, I'll say I want you to take 600 at 6, 600 at 8, and 600 at 10. That way we'll get it all in. But taking 1,800 all at once, I say you may as well just take most of those pills and pretend you're going to swallow them, but toss them into the toilet because that's where it's going to end up. Gabapentin anacarbol is a controlled release prodrug, does have linear pharmacokinetics. Take it at 5 o'clock with a fatty meal to get best absorption. FDA says 600 milligrams. Maybe you can get 1,200 from the insurance company. And you see here, here's what 600 looks like of immediate release gabapentin. Here's what gabapentin anacarbol 1,200 looks like. So much higher, much longer. question you always have to ask yourself is, if they have symptoms 4 hours at night, why am I giving them a drug that lasts for 20 hours? I generally think that that's a mistake. All you get then is side effects during the day. It's like using Klonopin for insomnia. All you get is side effects during the day. You want to use a benzo for insomnia? Use something that's going to be there for 8 hours, not for a few days. But that's a story for another day. Pregabalin. It does have linear pharmacokinetics, which is one of the nice things about it. It has a short-ish half-life, 7 hours or so, like gabapentin. So you may need to dose it multiple times a day if people have symptoms more than the 8 hours. Here's a study we did 2014, 10 years ago. I have to say, it's a beautiful, beautiful study. And I want to thank my colleague, now deceased, Richard Allen, and Diego Garcia Borragero. The three of us worked very, very hard on this study. It's a multi-site study. Whoopsie. Where people were randomized to either 300 milligrams of pregabalin, 2 doses to pramipexole, or a placebo for 12 weeks. And you can see that the higher dose of pramipexole and pregabalin beat placebo quite handily. The low dose of pramipexole did not. Then everybody who was on placebo got re-randomized to one of these 3 treatments for the next 40 weeks. So some people were on these drugs 52 weeks, some on them for 40 weeks. And at the end and throughout the study, we blindly looked at very detailed RLS diaries from all the participants and made judgments about whether people were having augmentation. And if people don't know what augmentation is, I probably should have a slide a little bit earlier about that, but we will be hearing about it. It's a worsening of RLS due to the dopaminergic medication itself. And as you can see, this is in the people who are on pramipexole for 40 weeks, 7.5 to 8% incidence of augmentation, 5% at the low dose. Pregabalin was 2%. I think this is basically just the weakness of our methodology and the natural worsening in some people. In people who are on pramipexole, as we'll see in a minute, for 52 weeks, it was a 9% rate of augmentation. So just going to stay here for 1 second, even though we're short on time always, just so that there's no confusion. They're no longer recommended as standard treatment. And it's a great disappointment, and I feel actually guilty myself because I did these studies and I gave these medicines to a lot of people and still do give them to some people. But in the long term, they're not good for many people with RLS. So these are the 3 big players. I'm not going to talk about levodopa. They're incredibly effective in the short term. I say it's like putting butter on a hot pan. They really work. And that in itself is one of the problems, because they are they make patients feel so good that their RLS is gone. They make us feel so good that we made it gone. They get rid of leg movements and sleep studies. But, and I say to people, it's just like this. We're lighting a fuse. I know it's at the other end of the fuse for most people. Let's say 50% of people, at least. I don't know how long the fuse is. Could be 6 months, could be a year, could be 3, could be 5. But it's going to blow up. Symptoms are going to start earlier and earlier and earlier and earlier. They're going to go from your legs to your arms. They're going to be more severe, and they're going to happen more quickly when you sit down or lay down. And the drug, the duration of benefit, instead of when you first take it it's 8 or 12 hours of benefit, and then it's going to be 6 to 8, and then less. So the duration reduces over time. Here you see the 9% risk in those people. This is from the New England Journal paper, 9% risk of augmentation at a year. I was very curious, how many people in the United States, how common is augmentation? Very difficult to figure that out. Very, very difficult. You have to see people at baseline before they get treated and then follow them for a long period of time. And it's really impossible to do that. So I thought I'd go about it the other way, and I'd use drug utilization data. And so you can go to IQVIA, it's a for-profit company, and get all prescription data for over 90% of US doctors or prescribers, nurse practitioners as well. And you can get diagnoses, you can get drugs, you can get doses. So I said, we're going to exclude anybody with Parkinson's disease, just RLS, and we're going to look and see how many people we had. 670,000 people. This is about 6 years ago. 60% of them on a dopaminergic, 40% on a non-dopaminergic. And then I said, okay, now let's look at doses, thinking that high doses, how you get to a high dose is you don't start there. You end up there gradually. And I gave pramipexole, maybe because I still have some fondness for pramipexole in my heart. I gave it a break. FDA says maximum dose should be 0.5 milligrams. I said, we'll accept anything up to 0.75, 4 milligrams of ropinirole. 20% of people taking those medications, about 75,000 people in the United States, above FDA maximum recommended doses. About 40,000 people over 150% of the maximum dose. That's over 1.25 milligrams of pramipexole, over 6 milligrams of ropinirole. You get there by being augmented. A lot of augmented people in the US. This is the primary challenge currently facing clinicians treating RLS, particularly in sleep medicine. We are trusted to manage the difficult patients. Most people, when this starts to happen, they just keep digging. Give them more, give it earlier, give it later, more. And I say this is putting out fire with gasoline. And the patient ends up feeling like this, and you end up feeling like this. If you want to see great surfing, went to Maui a couple years ago, and this is a beach called Jaws on Maui, which is a very famous surfing beach. This is a more than 50-foot wave. And this guy here is surfing it. And seeing patients with RLS who are on these high doses, you can feel a little bit like that. So how do you stay vigilant about augmentation? At the first time you see somebody with RLS, you get this information from them. And it's simple. It takes about 90 seconds. And then at every visit, you do the same thing. I say, I'm going to divide the day into 4 equal parts. At each of those times, I'm going to ask you how many times a week you have symptoms during that time period and how bad they are during that time period. So from 6 a.m. to noon, how many times a week? They say, I don't really get it then. Okay. How about from noon to 6 p.m.? 3 times a week. And is it mild, moderate, severe, or very severe? Mild to moderate. Okay. And I'm writing this down. From 6 p.m. till 11 p.m. when you go to bed. How many times a week do you get it? Really, pretty much every night. Okay. 6 out of 7 times. And how bad is it then? It's pretty bad. I'd say it's severe. And you do the same thing and you get a snapshot of severity, the temporal shape, the morphology of their RLS. And then you follow that. You have that baseline and you follow it over time. You see that it's really great during the honeymoon period. And then when the relationship goes south, as it does in some relationships after the honeymoon, you get to follow and see what's going on. Also be aware of impulse control disorders, gambling, spending, excess interest in sex or pornography, or binge eating. Less common in RLS than in Parkinson's disease because of the lower doses probably, but certainly you can see this. So you just need to ask, have any excess interest in gambling, spending money, sex, or binge eating? People look at you like you're weird, and they say no, and you say, okay, just checking, because these medicines can sometimes do that. And then you're going to hear from people, yeah, you know, my wife is really mad because I've been going to Foxwoods, that's one of our local casinos here, you know, like a few times a week, and I've lost a lot of money there. Well, did you gamble before you were on this medicine? No, not at all. That's the weird thing. It's just the last few years. That is a reason to immediately take a U-turn and figure out how to stop this medicine. Iron treatments, IV iron. Here you see change from baseline to week 1, get a little placebo bump or drop, you might have it with both. And IV iron continues to get better and better and better versus IV saline over 12 weeks. Weird that it takes that long. I'm used to giving somebody IV Ativan and their seizure stops like that. This is not like that for unknown reasons. EO iron, here in people with a ferritin baseline of about 40, -10 with iron, -1 with placebo. Quite effective. This is with iron 320 ferrous sulfate, 325 BID. I would not use that. I think that's just punishing. You know, as you know, probably know now with iron deficiency anemia, they're recommending iron every other day, not more than that, because you mobilize hepcidin, which then prevents absorption. So what do you do with IV iron? Well, you get their baseline iron indices. If they have a serum ferritin, I would say less than 50, or transferrin saturation less than 20%, then you can choose either oral or IV, depending upon what you and the patient decide is best for them. If they have a ferritin between 50 and 100, they're probably not going to absorb much oral iron. Our bodies protect us from absorbing iron if our ferritins are above 50 for really interesting and cool reasons and cool mechanisms. But in those cases, you're going to give IV iron. When you prescribe IV iron and write the requisition in somebody with RLS with a ferritin of 60, don't write RLS as the diagnosis.
Well, Rick, I think we're good, but we're not. Let me know.
Dr. Barkham, we're hearing every word that you say. I'm sure it's very interesting, but I'm not sure you want to share it with all of us.
Yeah, thanks.
Sure enough. And so write iron deficiency or metabolism, disorder of iron metabolism, because that will get the insurance to pay for it, because RLS is a brain iron deficiency, so it's perfectly legitimate. But if you put iron deficiency, they're going to see a ferritin of 60 and say, oh, it looks normal to me. So that's just a little pearl, if you will. I'm going to skip that. Opioids. These are extraordinary medicines when used in very low doses for RLS. What distinguishes these agents primarily, except for maybe some, is their half-life or effective half-life. And we want to provide opioids for the duration of time we want opioids in the brain. We don't want them to be exposed when they don't need it. Just like I was saying with gabapentin and acarbal or clonazepam. When do you want it in brain? So half-life and effective half-life are key. The other key thing is that look how low these doses are. This is what is used. Probably none of you are prescribing maintenance therapy for people with opioid use disorder, but it's generally above 100 milligrams. Same thing for chronic pain. For RLS, it's generally below 10 milligrams, less than 1/10 of the doses. So whenever you say opioids for RLS, you should always say low dose opioids, to be clear. Here is my PDMP report for the first quarter of 2024. I'm showing you mine, as we used to say in elementary school. And you can see here, this is now an MME for these months. It's actually 6 months. So the MME was a little less than 30, which corresponds to a methadone dose of 7.5 milligrams, oxycodone dose of 20 milligrams per day. These are low doses. I never thought I'd find myself in this position, honestly. You know, I feel a little bit like a guy who's got his picture up at the post office and like, oh yeah, Winkleman's the opioid guy. And, you know, I'm a pretty straight shooter here. You know, I have a drink occasionally, you know, but I'm not really a druggie myself. But I find myself prescribing low dose opioids quite frequently, and I am swimming against the stream. And so I read a lot about what allows somebody to do that safely.
You shouldn't.
And do you hear that? Yeah, I got that slide. I copied this from a talk that I gave, I think, when we were taping them during COVID, and it still has me talking, and it's terrifying when I hear my voice coming out of there. In any case, people who are one of these 3 C's should not prescribe opioids. But if you are not one of these 3 C's, and I got this from the paper you see down there at the bottom, which is a very nice paper, can safely, effectively, responsibly, without getting into trouble, prescribe opioids, low dose for RLS. But if you are careless, corrupt, or compromised, don't prescribe opioids for RLS. Before you prescribe, I would encourage you to use the opioid risk tool, ORT. Ask very quickly, does anyone in your family have a history of substance abuse or substance use disorder? Personal history of you yourself, substance use disorder? What's your age? Have a history of pre-adolescent sexual abuse? Do you have psychiatric illness? Add up the numbers and you get a risk stratification. Certainly not perfect, but reasonable. Always check the PDMP. I check it on every patient. Those people I'm prescribing CPAP for, I prescribe a lot of CPAP, I'm checking their PDMP. It's just too much fun not to. I don't know, maybe when I was a kid, I wanted to be a cop, but it's influencing all of their medical care. All those medications, whether they be benzodiazepines, stimulants, opioids, and so it's something that's reasonable to know about, in addition, of course, to knowing about all their other medications. I generally do not do a urine tox. Unless, and it's really only occasionally that I do it, unless I have real specific concerns. And at Mass General, we have to fill out an opioid agreement. And the patient does as well. The prescription you write for chronic RLS pain. Otherwise, if it's methadone, they have to pick it up at a methadone clinic. Chronic RLS pain, it explains to the pharmacist, because they're worried, of course, I'm worried, the patient's worried, everybody's worried. But this explains what we're doing. You do no longer need an X license for buprenorphine. You can write refills for anything but buprenorphine or tramadol. So you write prescription for today. I put it in Epic for a month from today and for 2 months from today, 3 months. And I see every patient who's on an opioid every 3 to 4 months, virtually, and in person once every 2 years. So since all treatments for RLS are based upon the 24-hour distribution of symptoms, that's what's cool about RLS. It's not an all day, all night thing like most medical disorders. It's just present during these particular times. And we have drugs that fit those times. So you choose your drug based upon the distribution of symptoms. Short symptoms for a few hours a day, use short-acting agents. Intermediate duration of symptoms, I'm going to use an extended release of, I use oxycodone, there are other extended release agents. Anybody with symptoms more than 10 hours a day, I want them to dose once. The last thing I want them to do is to be popping oxycodone 4 times a day. That's a recipe for a disaster, I think. So once a day, methadone or buprenorphine. Side effects of opioids, you go over in great detail with people. Constipation, everybody gets constipation. Almost everybody can manage it with the usual approaches. Daytime sleepiness can be present in people. Not a tremendous problem, but can be present. Itching sometimes, nausea sometimes, sweating can be bad sometimes. Men go through menopause. Why do they go through menopause? Is because opioids interfere with the production of reproductive hormones. So check a testosterone before and check a testosterone if people start to sweat or if you have any other symptoms of, if they have symptoms of low T, then I send them back to PCP or urology, they get testosterone, sweating goes away. Always check for central sleep apnea if you think that there's a particular concern. However, I'm not going to go through all these tables, but central sleep apnea in the doses that we use for restless leg syndrome are really generally not an issue. These are all retrospective studies. 2 of them just came from UCSD, Atul Malhotra's group, Jeremy Orr in his K23. Here you see mean MME of 30, which is kind of around where we are with our patients. Central apnea index, this is a large group of people. People without opioids was 1.7. That was the CAI. For people on opioids, it was 2.8. Yeah, they had 1 more central apnea per hour of sleep. It's statistically significant. Is that clinically significant? I think not. And you can see here the same issue. Here's another paper from 15 years ago, looking at central sleep apnea at low doses, really very, very small hazard ratio for central apneas. You get to the high doses, absolutely. Get to high MME, central apnea is a concern. Not at the low doses that we use. Our big concern about opioids is what happens long term. The last 2 things I'm going to talk about briefly are this opioid registry that I have, and then I'll talk about what to do with augmented patients. So we enrolled 500 people nationally in an RLS registry. They've been on opioids for 2 to 3 years before entry into the registry, and we interviewed them at length at baseline. and they fill out surveys every 6 months. And we're now just writing up our 5-year data. We have people now who are out to about 6.5 years. And I'll be presenting this, at the coming meetings, and we're writing it up for publication. The 2-year paper was published last year in Neurology. The 5-year paper, I'm hoping to aim high. I'm not exactly sure where, but it's 5-year data, 410 people still providing information, which is about 90% of the people who continue to be eligible. We have a very high rate of maintenance of people, very low attrition. The 90 people that we lost, a number of them died because people started off older, and that happens. And then there are many people who stopped taking opioids for their RLS. 50% of people increased their dose, the median by 15 MME. That's 10 milligram increase in oxycodone over the 5 years, and a 4 milligram increase in little less than 4 milligram increase in methadone. 30% remained on the same dose, 20% decreased their dose. Our big interest is in the people who increase it a lot. How do we figure out who's going to need to increase their opioid dose a lot? And those are people we need to know before we start to treat them with opioids for RLS. I get a lot of emails like this. This is why we lost 90 people. I would love to become a participant again. However, the last 2 sleep doctors have refused to give me opioids and insisted I take other medications, which do not work as well. Back to the dopaminergics, whatever. I live in wherever, can't find a provider who will help. I also suffer from severe arthritis in my back and several joints, and she was very kind, find it almost cruel to deny an 84-year-old woman pain relief. It was kind of her to say it was almost cruel. We've lost sight of what we're doing in medicine because of the opioid crisis. Everybody feels that they're at risk, their license is at risk. It's not true. If you prescribe these responsibly, there's a lot of data for opioid use in RLS. Neurostimulation treatments are coming. Okay, how do you handle augmentation? They're going to have to try to stop the dopamine agonist. I have restless dog syndrome here. Can you hear them barking? No, okay. So how do you get people off of dopamine agonists? It's not easy. It's not easy at all. What you do, first, add the new drug, alpha-2 delta, opioid, a combination, add that, get reasonable to good or complete control of the RLS with the new approaches. And then I would say decrease the dopamine agonist dose by 10% a month. So very slowly. The people who fail because they try to reduce it too quickly. Even at 10% a month, the first week after reduction is bad. Their symptoms are bad. They're in withdrawal. And you need to warn them. This first week's going to be bad. Hang in there. It'll improve at the end of that. And then you'll have a few good weeks where you're back to normal, and then we'll decrease it another 10%. I'm going to, if you want to know how I do it, this is a weird section that CHEST has in the journal called How I Do It. And they asked me to write something on how I do it for severe refractory and augmented RLS. And this is really kind of a very practical, operational, step-by-step. So I'm going to stop there. And I think I've gone right up to the time. And
That was fantastic. Thank you, John. There are some questions. I know you have another grand rounds to give right now.
I'll handle a couple questions. It's just the person, I'm giving grand rounds at the University of Calgary, and I have to fly from Ann Arbor to Alberta really fast right now. But let's just handle a couple questions. I just told them that I'm going to be on very shortly. So fire away, quick.
Okay, there's some questions in the chat about insurance coverage for gabapentin and acarbol, and also differences in side effects of gabapentin compared to gabapentin and acarbol.
Okay. Insurance coverage, you've got to get a PA. Or you can ask your local MSL, say, do you have any samples for me? I try to scrounge as much free samples as I can from the medical science liaison or the salesperson or whoever they are. And, they think you're going to be prescribing it like crazy to people who can afford it. And I'm just trying to get my patients free drug. And so I would try that. But yeah, it's a problem. It's a branded drug. In terms of side effects, I'm not sure I've identified any systematic differences between gabapentin and acarbol, other than the fact that you give gabapentin probably just at night, and you give gabapentin and acarbol at 5 p.m., but it's there all day. So just be aware that they may have daytime side effects that they wouldn't have with straight up gabapentin or pregabalin.
Thank you. And there was one follow-up question about insurance coverage for iron infusion.
Yeah, my experience has been very good when I write iron deficiency or disorder of iron metabolism. If you write RLS, there's going to be a problem. But iron deficiency, which is justifiable, as I said, I have 1-2% of the time maybe had a problem. Really, it's really been rare.
Thank you. I think those are all the questions.
Dr. Shogi,
Yes, go ahead, please.
Hi, this is Xinghang. Thank you for a great presentation. I have a few quick questions. So, given the change of recommendation, so now in your practice, for someone who failed the gabapentinoids, would you proceed to opioids as the next step, or you would still trial the dopaminergic with a detailed discussion on the potential augmentation or side effect of being?
That's the $1 million question. They failed iron, they failed gabapentinoids, hopefully not because you went too quick, started too high, but just because they had side effects at a low dose or it didn't work at a reasonable dose. Now what do you do? Dopaminergics or opioids? And I'm going to bail on this. I'm going to say, you talk to your patient about it. And you say, here's the pros and the cons. It's them. They're the one that's got to have the augmentation after you have finished your fellowship and moved on to your whatever you're doing next, or have moved away from Ann Arbor to whatever, and someone else. It's them. It's their choice. And unfortunately, then many of them say, what would you do? And I think I would probably use a low dose dopaminergic, warn, and document, and make sure you're checking very regularly for any sign of augmentation. And you're all doing all those things that make RLS worse. You're mitigating all of those, if possible. Switching them from Prozac to Wellbutrin, treating their OSA if you can, checking their iron, making sure they're not taking any histamine or Reglan, et cetera, et cetera, et cetera. But that's the $1 million question. This is where we are. It's 2024. I would think also about the bilateral perineal nerve stimulation when that becomes more available.
Okay. And then my second question is like for someone who have fear for addiction or dependence on opioids, like I know oxycodone is probably the one we use most frequently. So what's your experience with starting someone on buprenorphine or Suboxone for treatment for ALS? how effective are they?
In somebody who has opioid use disorder?
No, just generally for someone who have refractory RLS who is perceived
Opioids are extraordinarily effective. They're like dopamine agonists. I mean, they just work
Mhm.
really well at really low doses. You know, 0.5 milligram of buprenorphine. The smallest film or pill is 2 milligrams.
Right.
So a quarter of a film. And methadone, 2.5, 5 milligrams. I mean, they're really, if you haven't done it, you'll be surprised. And I have to apologize, but I have to fly to Calgary. Thank you very much.
Thank you so much for an incredible presentation. I got a message from somebody saying it was the best RLS talk they've ever seen. So thank you again.
Thank you. Thanks for inviting me, Anita.
Yes, of course. Take care.
Bye-bye.
See you soon.
Yep, bye.